It really is a pleasure to introduce our speaker, Dr. Ferric Fang. I've known him for almost 20 years since we were both at the University of Washington Department of Laboratory Medicine. Dr. Fang is an infectious disease physician and scientist. He oversees the clinical microbiology laboratory at Harborview and performs basic research at UW. And the point of that research is to understand how bacteria, maybe even viruses now, but usually it's bacteria, cause disease. Prior to joining the UW faculty in 2001, Dr. Fang was a faculty member at the University of Colorado School of Medicine. He is the founding director of the UW Interdisciplinary Training Program in Bacterial Pathogenesis, and he was editor-in-chief of the journal Infection and Immunity from 07 to 17. He's now, and this is what he's speaking to us about today from his experience as the deputy editor of Clinical Infectious Diseases. And that's the premier journal dealing with diseases caused by microbes, such as bacteria or viruses, and even parasites. There he has reviewed a vast number of manuscripts on COVID-19. He told me once, but it was so high, I thought I misunderstood it, and I hope he repeats how many articles have been submitted to CID. Dr. Fang has won numerous awards, authored perhaps 1,000 papers, he can tell us, and is one of my real heroes. Welcome, Dr. Fang.
Thank you for that very kind introduction, Jill, and it's so nice to see you and nice to see everyone here. So I'm going to share the screen. So there's really been an incredible tsunami of research on COVID, a disease that we hadn't even heard anything about before this year. And now there's over 80,000 papers that have been published, and people really can't keep up with it all. About 5,000 to 6,000 of those papers have come our way to Clinical Infectious Diseases, and we've been able to publish maybe 10% of them. And so reluctantly, I've had to develop some expertise about this virus. And it seems like every academic physician in the world is studying COVID from some perspective or another. So we really are learning a lot, and we're learning quite a bit that's sort of surprising. And if you want to see, I think an understandable, maybe at times slightly technical article, but mostly intended to give an overview that's understandable about where we are with COVID. In the last few weeks, I and the other editors of this journal, Clinical Infectious Diseases, published a paper called COVID-19, Lessons Learned and Questions Remaining. And there we kind of lay out the most interesting and surprising things that we've discovered about this pandemic so far, and then the really burning questions that are remaining to be answered. So what I want to talk to you about in the next 50 minutes or so is give you an introduction about this disease from the way that I've come to understand it, and then to focus on the measures that people can take short of getting vaccinated to limit their likelihood of acquiring COVID, because this is something obviously that we're all concerned about. And then eventually I'll mention a few things at the end about the vaccine and how that will change things. So where we first found out about COVID was in China. And this is still far and away the most likely place that this virus originated. And the first place we heard about it was in the seafood market in Wuhan, in the center part of China. And it was originally thought that this is really where the virus got introduced to humans. But now that we've been tracing back cases, it's become a little bit murkier. And there were clearly cases that predated the outbreak at the seafood market in Wuhan. So what I would say is this outbreak in the seafood market is what really brought attention and maybe amplified this problem, but it seems to have insidiously got introduced into the population sometime earlier, and we still don't completely understand that. So now it's become a pandemic, and the numbers as of today from the Johns Hopkins coronavirus Resource Center dashboard are really staggering. More than 70 million people have been infected worldwide, with more than 1.5 million deaths. And the US has had a particularly large share of cases and of deaths. Unfortunately, there's been a lot of variation from country to country in how things have been handled. And there are also factors that we don't completely understand, but have to do with things like seasonal factors, population density, the age of the population, potentially genetic factors, potentially genetic variation on the part of the virus. But for a variety of reasons, there have been really major differences in terms of the amount of COVID that individual countries have had and how much devastation there's been. You can go to some countries like Taiwan, for example, and or New Zealand, and it seems almost like no pandemic is going on. People are getting together for sporting events. They're crowding into bars and restaurants, and they're really not worried. And a lot of places, you don't have to wear a mask, and you don't really have to be concerned about everything. Now, some of that may be misleading because all it takes is one introduction of the virus and it could spread again, and they have to keep their guard up, and they have travel restrictions and so on. But life in those countries is going on, and it's a vastly different situation from what we're seeing in the US. In Washington State, these are data from the Seattle Times, which you can access daily. These are from updated last evening. And what you can see in terms of the cases in the graph on the top is that we've gone into our third wave. And this is getting amplified from the Thanksgiving season. My hospital, Harborview, has more beds dedicated to COVID patients than we've had since the beginning of the outbreak. And so unfortunately, it seems not only like our country has gotten the worst of it, but the worst of it may be yet to come in some ways. The next couple of months are going to be very rocky, and we're having high caseloads everywhere. Washington State was the first state in which this virus was found to be introduced into the country, but actually we've had a fairly quiet time of it compared to many other states, and we haven't had the enormous surges that have overwhelmed the healthcare system, but that could always change. And we're starting to get some really sick people in the hospital now. And you can also see the deaths lag a little bit because this illness is really protracted in terms of the time it takes to get really ill. And so when you see the caseload go up, then the death rate goes up usually a few weeks after that. And so the death rate has started to climb. It may not be quite as high an infection fatality rate, meaning how many people die per the number who are infected, as we've seen before, because we've seen a little bit of an age shift. In the first wave that we had a lot of patients who were very old who got infected in nursing homes. And now we're seeing younger people get infected. And as I'll show you, this is a virus where the clinical severity depends a lot on how old the person is. There's also a varied distribution within the state, and the most heavily infected counties corrected per capita have actually been in Eastern Washington and Southeastern Washington. And so Kitsap County has done relatively well. This is the virus. So when you see people talk about COVID-19, they mean the illness. When they talk about SARS-CoV-2, they're talking about the virus. And this is what the virus would look like blown up. These proteins studying the outside of the virus are the S or the spike protein. And it has two subunits, S1 and S2. And it's this that gives the coronaviruses their name, because on electron microscopy, it was thought that the spike proteins radiating around the virus looked like jewels studying a crown. And so it was named coronavirus. And the information that, the genetic information that tells the virus which proteins to make and dictates the type of virus is the RNA that's inside. But there are other proteins that make up the virus, which you can see designated there, but it's the spike protein that is really the target of vaccine research and the immune response. You may remember back in 2002, 2003, we had a scary outbreak of a respiratory infection called SARS. And the SARS coronavirus was really similar to this virus. It's about 3/4 the same. And so when SARS-CoV-2 first came on the scene, some of us were a little bit complacent because we thought we had SARS before, we dealt with it quickly, it burned itself out, it caused a lot of severe disease in people who got infected, but it really didn't spread very effectively in the population. And so we were caught a little bit off guard by how effective SARS-CoV-2 was in spreading through the population compared to SARS-CoV, the original SARS virus. And I think what we've learned is part of this has to do with subtle differences in terms of the immune response to the virus, that SARS-CoV-2 is a little bit stealthier. And even though they bind to the same receptor protein and they use some of the same processes, and they have a lot of structures the same, this virus doesn't elicit as strong an immune response when it first encounters the host. And so it sneaks past the defenses. And by the time the alarm bells go off, it's already established itself, and it can then engender an inflammatory response that causes the severe illness. But most importantly, for the spread of the virus, it means that the alarm bells that go off that cause the symptoms associated with viral infection are delayed. And so people walk around spreading virus and they don't know that they're sick. And this is a really big difference from SARS, because SARS made people ill very early, and you would recognize them as ill, and they would feel ill, and they would not go out, they wouldn't go to work, they wouldn't get on public transportation, they wouldn't hang around in bars and sing karaoke and go to restaurants and spread the virus everywhere. So these little differences, really, these viruses are cousins, but they're so different in terms of how they've affected us because of this biology. When SARS came out, people started looking for coronaviruses and wondering where these coronaviruses came from. And when people looked in bats, they found this astonishing diversity of coronaviruses in bats. And I think it's now widely acknowledged that bats are the primary reservoir for coronaviruses in nature. And this is a horseshoe bat on the left, which is the primary reservoir host for the SARS coronavirus. And so we can find lots of cousins of SARS-CoV-2 in bat viruses. We haven't found the smoking gun, the exact SARS-CoV-2 isolate from a bat, but there are such close relatives. I think it's strongly believed that bats are the ultimate source of this virus. When the virus gets into the body, the primary tissues that get infected are in the respiratory tract and in the gastrointestinal tract. We still don't completely understand how significant the GI tract is to illness. Once we found out the virus could infect the intestine and be shed in the stool, there was a lot of worry that perhaps it could be spread by foodborne transmission or by what we call fecal oral transmission, which is sort of distasteful, but unfortunately, it means that fecal material does find its way into things that we ingest into food or water, or by other routes. And this is an important route of transmission for a number of pathogenic organisms. But this route of transmission has really not been shown to be important for COVID-19. And I think most people believe that it's not. I still worry a little bit about the potential for someone who's shedding a lot of SARS-CoV-2 in the GI tract to potentially be disseminating it by aerosol, because when you flush a commercial toilet, there's an enormous plume of aerosolized material that is generated throughout the restroom and can stay airborne for hours. And so one of the things we haven't really figured out yet is whether this is a meaningful route of transmission. There have been a few kind of freakish arrangements of situations where we think plumbing systems have actually disseminated SARS or SARS-CoV-2 by an airborne route from plumbing systems. But we think that that's exceptional, and that the vast majority of infections are acquired from person-to-person airborne transmission. These are the common symptoms of COVID-19. Remembering, though, that maybe 45% or so of infections are asymptomatic. So you can have the virus and have no indication that you're sick at all. But when you do develop symptoms, the common symptoms are cough, fever, chills, muscle aches, not very specific. If you get more severely ill, you can become short of breath. Sore throat is noted by some people. And then this unusual symptom of losing your sense of taste or smell is pretty distinctive for COVID-19. This tends to be found in people who have milder illness, but it can still be kind of a disturbing symptom. Some people who have it find it comes back pretty quickly. Other people still complain 2 months out that they can't taste or smell anything. But fortunately, most of them by 6 months seem to have regained their sense of taste and smell. The reason for this seems to be that it has a tropism. It targets these cells that are in the nasal cavity that are these specialized cells that connect to the neurons that allow us to smell things and taste things. And these cells end up actually directly infected by the virus and can be killed. And that's why these symptoms are so prominent. This is a technical diagram from a review article, but it reminds me to tell you this very important principle about this virus. So, you know, all viruses can get in and infect cells, and they replicate and they damage those cells, and then our immune cells come in and find the infected cells and kill them. And, you know, most of these viral infections we can get regularly and we can recover from them. But the unusual thing about SARS-CoV-2 is that it gets into blood vessel cells. So this is a cartoon that symbolizes a blood vessel, and you can see white cells and red blood cells, blood coursing through the vessels. And what happens when the virus gets into the lining cells of the blood vessel, called endothelial cells, is they can activate inflammatory proteins, they can cause blood clots to form, and they call on inflammatory cells like neutrophils to come in and release their products. And they can end up generating a lot of damage in whatever organ this blood vessel is in. And it's really this combination of inflammation and activation of inflammatory pathways, a pathway called complement, and the recruitment of white blood cells, and the damage that they do to tissues that makes this such a problematic infection. People will clear the virus and then get very ill from the inflammatory response and from the clots that form. And a striking thing that we found from autopsies that were performed on patients who died from COVID were that many of them had blood clots all over their body. And a lot of the damage they were having was a secondary problem. It wasn't because the virus was getting into the liver and killing the liver. It was because the virus was getting into the blood vessels, and the blood vessels were clotting off. And then that in turn was damaging organs like the liver. And so you can see things like heart damage, kidney damage, liver damage, brain damage in people who have severe COVID. And it's not because the virus is directly mediating that, but it's because of this secondary process. It also, in the lungs, it elicits this syndrome called ARDS, or acute respiratory distress syndrome, where the airspace of the lung, which normally, should see this nice slender border around the cell, and then you see this space full of air where we breathe in the air and we have gas exchange across these cells. But this starts to fill up with fluid because it gets damaged because of these particular pneumocytes, that these lung cells that get infected by the virus. And so this is really, these are really the central pathological events that happen in COVID-19. It's not just the virus and getting rid of the virus, it's all of the secondary events that are happening in the body that cause the disease. This is a figure that came out from the Chinese Centers for Disease Control very on, and it's been very helpful cartoon to kind of give you a big picture about what happens with this virus. It doesn't include the bit where about 40 to 50% are asymptomatic, but these are the people who have some symptoms. But if you take every 100 people, 4 out of 5, about 80%, will only get mildly ill. They don't have to get in the hospital, they'll get over it. About 1 out of 5 get sick enough so that they have to come into the hospital. And then about a third of them get sick enough that they have to go into intensive care. And then of those that go into intensive care, about half of them require ventilatory support. And it's out of this group of people where you can start to see a significant number of people who will die from the infection, the ones who need ventilatory support. There are occasional people in this other group who have sudden death, And it's a variety of mechanisms, and it probably has to do in part with these blood clots that I've told you about. But a lot of the deaths happen in the people that have respiratory failure, and they end up needing to have a ventilator breathe for them. So this is where part of the confusion comes from, right? Because you've got almost half of the people who have no illness at all. And then you have of the people who have illness, 4 out of 5 of them only get mildly ill. And so if you are looking at all these people who get COVID and you see that they feel like they had a cold or a mild case of the flu and they got over it, you're saying, what is the big deal? But the big deal is we can't completely predict who's going to go on to have these terrible things happen. And in the end, because so many people are getting infected because this is a new virus and we had no pre-existing protective immunity to speak of in the population of the world, that the virus just keeps having its way with us. We've come to take it for granted that we're immune to most viruses because we've had a history with them, and our species has developed immunity to a lot of the viruses that we see. But when a new virus comes out because of this transfer from animal viruses to humans, this is where really terrible things can happen, where you can get these pandemics because you have a completely vulnerable population. And so once we knew that this virus was on the loose and it could be transmitted, we weren't comforted by the fact that most people don't get sick, because we knew there are so many billions of people in the world. If everybody is going to get infected, we're going to have a lot of people in the ICU, a lot of people needing ventilators, and a lot of people unfortunately dying. So this is a kind of a convenient cartoon for how a doctor views the stages of this infection, where you get the viral infection, and this is just the instigator for the whole process. And for some people, this is all that's ever going to happen. But we want to watch people very carefully to see if they start having lung damage, because if they have that lung damage, then they might end up needing ventilatory support. And it's really, you're talking about 2 weeks into the illness when things start really going to hell. And you start getting all of these blood tests that become abnormal as a sign of increasing inflammation and increasing signs of tissue damage. By this time, the virus is almost gone. And so if you give an antiviral agent, you actually can't really accomplish very much, because the host defenses have largely cleared the virus. And now you're dealing with the huge mess that the virus is making in the body. And that's why we have to very carefully look at each patient and figure out where they are in their progression. And each individual, shows some differences. And then if we figure out that the problem is blood clotting or the problem is inflammation, then we can give the specific drugs to try to inhibit those processes. If you're going to inhibit the virus, you need to do this very early. So you see people like President Trump or Rudy Giuliani going to the hospital and getting treated with cocktails of antibodies against the virus. That's because they got diagnosed very early and they're brought in promptly and they're given these therapies to try to neutralize the virus. By the time you'd get to these stages, it would be too late for things like that to work. And then we're giving things like a corticosteroid called Decadron or dexamethasone and some other experimental drugs to try to dampen the intensity of the immune response. If you've had COVID, and even if you've had mild COVID, you're not necessarily out of the woods. And we're starting to find out that people can feel poorly for a long time. These are some of the symptoms that are reported by people who survived COVID. And not all of them had severe COVID. Some of them didn't even need to be in the hospital, but they just never came back to normal. And this is called long COVID or long haul COVID, post-COVID syndrome. And we're seeing these kinds of chronic nagging symptoms go on for months. If you talk to people who had COVID, young, healthy people, 3 months after COVID, and you ask if you're back to normal, a sizable percentage of them will say, I'm still feeling poorly. And they feel, what's wrong with me? My body's just not getting better. The virus is gone, but they continue to have these symptoms. And it's definitely something that's going on that that I think is yet another reason to really try to not get this infection. So here we have, and I'm sorry for showing you some data, but I think I want you to understand that there are really hard data behind some of these generalizations that you hear people talking about. And the reason that we feel confident about these things is because we now have information from thousands and thousands of people that have really been consistent over time. And this is a graph where on the left side, we're looking at the different ages of people, all divided up by every 10 years. So these would be the youngest children, less than 10 years old, and these would be the oldest people, 80 years and older. And then we're looking in blue at the number of infections. So what you can see is in this large experience from China, almost 50,000 people who got COVID, that there was a whole distribution of people who got infected, but most of them were adults. But if you look at the people who died from COVID, the distribution is strongly skewed towards older people. So it's much more likely to be severe and fatal if you're older. And as someone who's in the 60s, you know, this makes me a little bit nervous, but it's also not a reason to be completely complacent if you're young, because there are some severe cases and some deaths, even though the risk is lower. And if you separate this out by sex, you find out that men are worse off. And this has been consistent in virtually every study that's looked at this. These are just some data from Washington State and from California, from a UC Berkeley epidemiologist. And I thought you might be interested because they came from our own state. But this has also been looked at in many, many different places. And it's clearly true. And you can even see it in animal models that being female is somewhat protective, and it's especially protective if you have during the reproductive years, if you have high levels of estrogen. And it looks like estrogen dependent signaling may play some role in the sex differences that are seen, but it may be more complicated than that. Overweight people are also at more risk of having severe COVID. This has turned out to be a major risk factor. And if you look at the younger people who get into trouble, a lot of them are overweight. And this probably has to do, it's not completely understood, but it probably has to do in large part because obesity has been associated with more inflammation. There's a lot of inflammatory pathways that are mediated by lipids in the body, and especially having a lot of abdominal fat is a marker for having more of a hyperinflammatory profile when you get the right trigger. And this might be one of the reasons that COVID can be so severe in people who are overweight. And of course, with everybody at home distancing and not being able to get out to work and do the activities that they do, most people are putting on 15 or 20 pounds, and then it makes them even more anxious to realize this relationship, but it's definitely there. So here's a medical photo, and it's mainly to remind me what I wanted to tell you, to emphasize from, this is an autopsy of some patients in Switzerland who died from COVID. And you can see evidence in different organs that it's these blood vessels that are infected with the virus. And it's this ability to infect the lining cells, the endothelial cells of blood vessels, that I think is really distinctive about this virus, and one of the reasons that it's so deadly, because once you damage the lining of the blood vessel, then you can get clotting, and then you can't get blood flow where it needs to get to, and then those parts of the body are going to die. This is actual imaging from people with this new technology of this high resolution imaging, where you can see the airways in blue, and you can see the arteries and veins. And what you can see just from anywhere you're sitting in front of the screen is that these lungs look really different color. This is a pair of healthy lungs of someone who had imaging. And what you can see here is these are a lot less pink in the patient who had COVID. And there's all of these beaded appearances. Instead of these nice filled vessels full of blood, you're seeing all of these cutoffs and these narrowings. And it's because of all the microvascular problems, the problem with the normal regulation of the blood vessels and the problem with small blood clots that are happening in the lung circulation, that is a major distinctive feature of COVID. And so we have all these different drugs that we're trying to use to treat COVID, but they all work at different points in the cycle. Some of them work on the virus itself. Some of them are working at the early stages of infection. Some of them are working at the inflammatory response that's induced by severe infection. And some of them are working on blood clotting. And which ones you want to use and you want to test depends very much on the patient and where they are in the progression of their illness. And this has made it doubly difficult to do clinical trials of these different agents. because you have to define your patient population very carefully. Otherwise, it might look like nothing works because you have to have only the right time and kind of patient in order to have that drug uh, beneficial. And we've tested many, many drugs, and most of them have not been effective, or we are still not sure. These are just data to show that nearly half of the infections are asymptomatic. And we've seen that in all kinds of settings now, and it's clearly true. And it's not only true of young, healthy people, it seems to be true, even in people in nursing homes, a lot of people are asymptomatic. And so why do some people get the same virus and they carry it around, and sometimes large amounts of it, and they have no illness, and other people are terribly ill? It probably has to do with multiplicity of factors, including, most importantly, the immune response to the virus. And we've now identified certain genetic markers that are predictive of susceptibility to the virus. But it also seems to be more than that. Part of it may be the amount of virus that you initially get exposed to. If you get a small amount of virus, you may be able to engender a protective immune response that protects you from going on to develop more severe illness. But if you get a really large dose of the virus all at once, then it may overwhelm your immune system and cause more disease. This is not proven, but in animals, it looks like the dose is important. And so it may well be important here as well. This graph shows measurements of the virus by the PCR assay over time. And on day 0 is when the people are believed to have first gotten symptomatic. And so what you can see there is that when you normalize all these data, you have this kind of monotonous downhill slope where the virus gets cleared after about 2 to 3 weeks. And these are measurements that are made in throat swabs, but you can see the same thing with these nasopharyngeal swabs. The ones in blue are the ones who hardly had any symptoms, and the ones in red are the ones who are severely ill. And what you can see is it's not really very different. If you have severe illness or mild illness, it's really how you react to that virus. It's not the amount of virus that's present at the time that you get symptomatic. And so I promise you this is the last complex piece of data of this nature I'll show you, but it's really to remind me to explain it to you. So we look at things in epidemiology where we look at when people first become symptomatic and when they're likely to come into contact with other people and then spread to them. And we do this by contact tracing. And so there have been really painstaking studies where they took a community where there was no COVID, and then COVID got introduced and there was an outbreak. So you can identify everybody who got infected, and you can see who they probably got it from, because you can trace from person to person how the outbreak progressed. And you measure how long was the incubation period, which means the time from when you got the virus and the time when you started to develop symptoms. And you look at what's the distance in time between cases, and that's called the serial interval. And if you have a scenario where the serial interval is longer than the incubation period, then this is like what happened with SARS. And so you have mostly people who are symptomatic transmitting. And this, as I said, turns out to actually be better for us to control, because we can recognize if someone's coughing or sneezing, and we can say, we better put a mask on them and make them stay home so they don't infect anybody. But what happened with SARS-CoV-2 and COVID-19 is that it turned out the serial interval was shorter than the incubation period. So people would transmit while they were still incubating. And this is called pre-symptomatic transmission. And this is really the key feature that makes this virus so problematic from an epidemiologic point of view. The fact that there are all these people out there who don't think they're sick, who are shedding large amounts of virus. There was a case in Korea where a pre-symptomatic patient, the day before he became symptomatic, was celebrating that they had reopened the bars and went to, like 30 different bars singing karaoke, and all of them spraying virus all over the place, and they had a super spreader event. So what we've come to learn is that about 10 to 20% of the people who have COVID are responsible for about 80% of the spread. And this is a very important principle, because it tells us that we don't have to stop every last transmission in order to cause this virus to die out in the community. We need to identify these really high-risk settings. And the 3 C's are a way of remembering these situations that you do not want to be in. One of them is a closed space, a stuffy place where there's poor ventilation. So this is a restaurant packed full of people, doesn't have very much ventilation. And so the air recirculates. And when people aerosolize virus through just breathing and talking into the air, it hangs around for a long time. And then a high density group of people, even if you're not in a closed space, if you have a lot of people close together, and so a high density and in close contact, these are the 3 C's: closed spaces, crowds, and close contact. This is really a powder keg for the spread of this virus. This is an epidemiological analysis of where people spread to other people. And this shows this whole cluster that came from one person, person B. So a lot of these cases, they only went to one other person or to no other person. But this super spreader cluster, one person ended up leading to infections that caused all of these different events. And this is a super spreader event that came out from a bar in Hong Kong. We had a super spreader event early on in Skagit County with the Skagit Valley Chorale. They had debated, because of hearing about COVID, whether they should have a rehearsal, but they decided to go ahead, and about 60 or so of the choir members decided to get together, and they weren't socially distancing. And now we know that singing is one of the activities that is most dispersive in terms of this virus. And so everybody was asymptomatic, and it ended up that 87% of the people in the rehearsal got infected because they were in a closed space. There was a crowd of them together. They were packed closely together, and then they were singing, which is a very high risk activity. And so the virus was filling the room, and they were all breathing it in, and 87% of them got sick, and 2 actually died, even though nobody was symptomatic at the time of the rehearsal. So this is clearly a super spreader event, and very clearly, in my mind, evidence of the airborne nature of how this is transmitted. There was another interesting airborne event in a call center in South Korea, where they found out that almost all the infections were people working in a crowded room on one side because of poor ventilation in the building. And this also is an example of an airborne spreading event in a crowded room. And then restaurants have turned out to be a risk factor for getting this virus. And this is an analysis of a restaurant in Guangzhou, China, where it turned out these people were sitting more than 6 feet from the people who had the infection. This is the patient who had the infection, but it ended up being spread all around to these other tables because of the circulation pattern of the air from the air conditioning system in this restaurant. And now there's been another restaurant associated set of case cluster in South Korea, where they've also analyzed it and shown that it's airborne transmission that's promoted by the ventilatory pattern of the air conditioning system in the restaurant. Here was another likely super spreader event at the White House at the reception for Amy Coney Barrett, where a number of people with the right time course for the incubation period came away positive. Even though they were outdoors, you can see that most of them are not masking, and they're all sitting close together, and they're probably yelling out, and cheering. And these sorts of activities are really good for spreading this virus. Jill may not have told you, but her daughter Christine is a really superb reporter, and she wrote up recently a super spreading event in Ritzville, Washington, in southeastern Washington, where there was a wedding that more than 300 people attended near Ritzville, near the Tri-Cities. And unfortunately, some of the people who attended the wedding worked in nursing homes. And this led to 40 cases of COVID in these clusters in nursing homes, another super spreader event. This shows how difficult it is, even if you know that your elderly people are particularly vulnerable and you want to protect them and keep them out of circulation. A lot of our elderly people in this country don't live in nursing homes, and we can't completely isolate them and wall them off. We have people who work there. We have family members who see them. And what we see is that when young people have COVID spreading in the community, it very quickly spills over into uh, skilled nursing facilities with terrible consequences. So there was a debate for a while in epidemiology about whether this is really being spread by so-called droplets, which are primarily believed to be deposited on surfaces and get on your hands. So people were saying, be careful about touching your face, wash your hands. Could be spread by objects, which are called fomites in epidemiology language. But a lot of modern evidence, this was really based on science that was done in the 1930s. A lot of modern evidence indicates that these kinds of separation of airborne and droplet routes of transmission are really outdated. And that nowadays we realize that when people talk or sing um, or just breathe, that droplets of an enormous range of sizes come out. The heavier ones deposit on the ground first, but the smaller ones can stay airborne longer, and the very small ones can actually stay airborne for hours. And so these can be transmitted. Most commonly, we believe COVID is transmitted by being fairly close to somebody. If you stand about a foot away from somebody and you have a 10-minute conversation, you've really exchanged enough air with that person for them to be infected if you were infected in the first place, unless you're wearing masks. And then longer range airborne transmission probably requires some special circumstances like poor ventilation or an air conditioning system. But this is the way that we think short airborne transmission is happening. So you can protect yourself by wearing a mask, but you protect yourself even better if the person who has the source of the virus is wearing the mask, because the masks work better at the source than they do in the recipient. The reason for that is not completely understood. It's complex, but it may have to do in part with the fact that as the droplets pass through the air, they become less and less hydrated. And this is particularly aggravated in the winter where it's cold and we have the heat on and the humidity falls. And when the humidity is low, then your aerosolized droplets become dehydrated more easily and they can spread farther. And so humidifying the air in a building is actually an important intervention to try to reduce the spread of respiratory viruses. And if both the person who's infected and the person who's receiving the virus are masked, then it dramatically reduces the likelihood that the virus will be transmitted. These are some data to show that it's not just coughing or sneezing, but talking and breathing, every kind of activity where air is being exhaled can result in expelling particles of a variety of sizes, including some that are carrying viruses. Speaking loudly actually makes a big difference in terms of how many aerosolized particles you're expelling and how far they go. And so you can imagine that singing at a high volume is one of the highest risk things that you could possibly do. If you put a mask over the person, you can see that these exhaled viruses are dramatically reduced in terms of them coming up. So here we're looking at the virus copies that were collected and quantified by PCR. And then if you look to measure the particles coming out of the person breathing, not wearing a mask, you can detect the RNA from the virus, but if you put a mask on, it goes away. And you can see that with aerosolized and larger droplet particles. So wearing a mask helps a lot for the people around you, but it also helps you as well. There's this lovely video that I recommend to you that was posted on the Washington Post this morning. And they used infrared imaging to be able to visualize the carbon dioxide that people were inhaling. And you can see them talking and you can see the air go back and forth and visualize the currents. They point out that the carbon dioxide is actually probably underestimating this very small particles that can be carrying virus, but it nevertheless shows you what a difference masking makes with these air currents. When you wear the mask, you still see the exhaled CO2, but it goes up and around the mask. And interestingly, a lot of it goes backwards. So if you've been standing in line, at the post office with a bunch of people wearing masks, you shouldn't stand too close because the exhaust is all going backwards. And it's actually worse than if they were breathing in your direction because the mask is diverting everything behind. You don't want to get in one of these human conga lines. Now, some really interesting data came out of this great virologist named KYUN in Hong Kong with a hamster model that he developed. And he actually looked at the value of masking in this hamster model. This is kind of a joke of trying to get the face mask on the hamster. What they really did is they had cages with hamsters and they put mask material in around the cages to mimic the hamsters wearing a mask. But they were still able to see that masks were protective against transmitting virus from one hamster to the other. And they were more protective when the mask material was closer to the hamster that was infected than when they were in the recipient hamster. So this goes along with what I was telling you, that the mask is most protective when it's worn by the infected person. So we don't know who's infected, we should just all wear masks. But it did also provide some protection to the recipient. When the early COVID pandemic was happening, the Financial Times plotted all these trajectories of different countries, and you can see what a lousy job we were doing here in the US. We were having this very rapid doubling of cases, and all of these countries had in common that they had a no mask policy early. And the countries that immediately instituted a universal society masking policy, all from Asia, had a dramatically lower rate of case increase. Now, it wasn't just masks, they were doing a lot of other things, but it was interesting to see how that shook out. And we have also seen that the longer a country took to make a mask mandate, the more likely they were to have fatal cases of COVID-19. These are countries that masked early, and these are countries that didn't mask universally or had a delayed response. There was a big exposure with two hairstylists who actually had symptomatic COVID and continued to work in Springfield, Missouri. And it had all the hallmarks of a super spreader disaster. But 139 people who had their hair done by these two stylists, none of them got infected because the salons had a masking policy where both the stylists and the clients were wearing face masks. And so this shows you, even with somebody who has symptomatic COVID, it's not that infectious if we do some simple measures to try to protect each other. This is some data, interesting data from my journal, Clinical Infectious Diseases, where they looked at the effects of wearing a mask on your likelihood of developing an antibody response. And they found that the more effective you're masking, the less likely you were to get infected and get an antibody. But interestingly, the people who did get infected were more likely to be asymptomatic. And this suggests an interesting function of masks, that even if the mask doesn't completely protect you, it may lower the dose of the virus so that you're less likely to get symptomatic illness. And this is called variolation, this idea that giving a little bit of the virus could be protective because it induces an immune response. And it harkens back to Edward Jenner and taking material from women who had cowpox. That's where the name vaccine comes from vaca or vache for cow, taking the cowpox and inoculating people in order to generate an immune response against smallpox. And so it's been proposed, not proven, but with some plausible mechanisms, that maybe getting exposed to a small amount of this virus because you and the other people are wearing masks could actually engender some protective immunity without you having to get sick. Now, obviously, this is a risky way to get immunity, and it's not something I'm advocating, but it may be a beneficial side effect of having masks. These are some data where they look to see statewide whether the public was mostly wearing masks or whether they were not, and correlating it with number of COVID cases. It's a little loosey-goosey data, but it was kind of interesting how it laid out in kind of a linear way. And Washington State is actually pretty good as masking goes. Another similar kind of data is from the New York Times, where they were surveying to see the likelihood that you would run into 5 people in a row who are wearing a mask. And it's mostly on the coast where you see that. And it looks like a backwards image of this, which is a real-time indicator of your likelihood of running into COVID when you get together at an event with a lot of people gathering. So going back again, that the places that are more likely to have masking are the opposite of the places where you're more likely to run into COVID. And I don't think this is coincidental with so many counties. I think, we've come to the conclusion that universal masking is a good idea when you have a widespread virus that spreads by a respiratory route. These are data from Vanderbilt where they looked at counties in Tennessee that adopted a masking policy because of a rise in cases and the ones that didn't. And you can see this nice correlation looking at almost 100 counties in Tennessee. Now, interestingly, this has ended up falling out along partisan political lines, where if you look at counties, depending on whether they lean towards the Democratic or the Republican candidate back in 2016, was predictive of whether or not they would be wearing face masks. This is something I never would have predicted, that it would become a political issue about trying to save your own life and saving your neighbor's life, but it has gotten terribly politicized, and I think we need to do everything we can to take the politics out of this issue. But right now, the country is very polarized on this and other matters, including the vaccine. When you add everything together, you end up with this kind of a matrix where you look at the activity you're doing. Are you keeping your mouth quiet? Are you speaking? Are you shouting or singing? Are you wearing face coverings or not face coverings? Are you having a well-ventilated room or a poorly ventilated room? Is it crowded or not crowded? And you add everything up and you can kind of estimate how risky this is. So it's not black and white, but it's an additive effect of all these things that you're doing and how much time you're doing it. And the New York Times had a cartoon to kind of show this idea that it's really what they call the Swiss cheese model, where a mask doesn't completely protect you. Washing your hands doesn't completely protect you. Avoiding crowds doesn't completely protect you. But all added up, it's like a bunch of slices of Swiss cheese. It becomes harder and harder for the virus to get through all of these barriers if you do all these things. Some of these things are things we do together. They're community responsibilities. Some of these things are things we do individually, like wearing a mask, washing our hands, staying home if we're sick, and so on. And I think this is conceptually a really nice, simple way of thinking about it. Nothing is foolproof. Even a vaccine is not foolproof. But we want to do everything we can to minimize our risk and also the risk to others. There are different kinds of masks that you can wear. Different studies have come to different conclusions about how good the different materials are. In the hospital, the N95 is going to be a better material in filtering really small particles that are airborne than a surgical mask. But surgical masks have turned out to be surprisingly good in the healthcare setting, particularly when N95s aren't available. In the community, mostly people are wearing fabric masks unless they have access to surgical masks, and they're leaving the N95 masks appropriately for healthcare workers. But there it matters a lot how you wear the mask. If you wear the mask properly, you really want to have it a tight seal. There's a paper in JAMA Internal Medicine a few days ago that looked at the differences in terms of how tightly you tied the mask and whether you tucked in the corners and so on. And it does end up making a difference, not having a lot of air leaking around it. Even the cloth masks, the cotton masks, nylon masks that have a couple of layers ended up filtering reasonably well if they were worn properly. Now, when we look at the spread of COVID in the community, and I just have a few more slides, I'm going to finish up. If you look at the spread in the community, if everybody lacks immunity, it's very easy for the virus to spread rapidly. If you get a certain percentage of the population that it's immune, then even if someone gets infected, it's unlikely that the virus can run into a susceptible person and infect them, and that's called herd immunity. And so you've heard discussions in the news about whether we should be going for herd immunity as a protective mechanism. The trouble is by natural infection, to get 70% of the population immune means that you need to have an awful lot of infections. According to the CDC, most of our states were less than 10% seroprotected as of a couple of months ago. And in order to get enough people infected would mean we'd have so many people dying that it wouldn't be worth the cost. So herd immunity is best achieved by vaccination because the vaccine won't kill people and they can generate protection. And what we really need now is to vaccinate enough people to have about 70% of the population predicted. Until then, we have to be socially distancing because socially distancing reduces the number of people that you're going to run into that you can infect. And this can have a major effect then on the rate of the spread of the virus and how many people get sick over time. And that's what's so-called flattening the curve, is if you can reduce the number of cases over time, you can prevent from overwhelming your healthcare system until vaccines can come in and everybody can get protected. So the vaccines that we have right now are these mRNA vaccines, which are an interesting novel kind of vaccine technology where they inject the mRNA and it just has to get into the cytoplasm of your cells and it starts getting translated into protein and it makes that spike protein. There's no virus in there. There's no viral vector. There's nothing to replicate. So it's just the RNA, but the RNA is also an adjuvant. So it stimulates an inflammatory response, the type 1 interferon response that you need to have also to generate a good immune response to the vaccine. So unfortunately, that means the virus, the RNA fragment that gets into you will make you symptomatic. That about 10 or 15% of people get a flu-like disease and they get soreness at the spot of the injection. And sometimes it seems the booster is even worse. Don't worry about this. It doesn't mean you're getting COVID from the vaccine. You can't get COVID from this vaccine. It means actually that you're responding to the vaccine just like we want you to. There are also protein subunit vaccines. There are attenuated whole viruses, and there are like the AstraZeneca Oxford vaccine, where they take a different kind of virus that's not virulent, and they put the SARS-CoV-2 nucleic acid in it. All of these are legitimate vaccine technologies. They all have their strengths and weaknesses. But right now, I think the two vaccines we're looking at, Pfizer and Moderna, are using this RNA principle. This is from an animal study where they used a different vaccine preparation. And what you can see is that the protected animals had completely normal lungs. This may look awful to you, but it's actually a micrograph of normal lung. Nice thin walls, not too cellular, lots of air spaces where we can breathe in. The lower dose of the vaccine gave partial protection. So the animals still got some illness and there's some inflammation, but they survived. And without it, without any vaccine, then the lung turned into a solid mass of inflammatory cells and the animals died. So these vaccines look very effective. The AstraZeneca vaccine, it's a little bit confusing because of some mistakes that were made in the clinical trial, but it also looks like it's going to be quite effective. And you know, I, for one, can't wait to get vaccinated. I know that it's not going to be a walk in the park, but I think it's our way out of this mess. And everybody I know in the healthcare profession is really excited for all of us, our coworkers, our patients, to all get immunized so that we can try to get back to our lives. So here's a list of the things I've told you. COVID is spread primarily from short range airborne route. If you don't want to get it, keep a safe distance from other people. 6 feet is not magical. The farther you get, the better, because gravity will pull large droplets out of the air. But even longer distances could be an issue when you're indoors and there's poor ventilation. You should wear a face mask at all times when you're around others, especially indoors, except with your immediate family household bubble that you're with all the time. You should keep rooms as ventilated as possible and, if possible, humidified. Avoid crowds, avoid settings where there are people speaking loudly, shouting, breathing heavily, singing. So gymnasiums, bars. Wash your hands regularly. Disinfect, avoid touching your face, which I just did. Disinfect high-touch surfaces. And understand all the symptoms that I told you about COVID so that if you have any of them, you can stay home and avoid others. And please get vaccinated when a vaccine is available. So I'd be happy to entertain questions and to stay as long as you'd like to answer them. Thanks very much.
Thank you very much, Dr. Fang. I've summarized some of the questions. The first group is for how to wear the mask if you, one, have a beard, and two, for me, I've tried to push it in through my nose, but still the air seems to go up to my eyes and steam up my glasses. So, so how do you wear the mask to be more comfortable, we'll say, and for beards?
So the CDC has a chart that you can get online that shows you different styles of beards. And there's like 30 styles of beards, and some of them are mask compliant and some of them are not. And so you have to consult that chart because most of the beards are not compatible with getting a good seal, unfortunately. So if you work in a hospital setting, you have to get rid of certain kinds of beards, but there are a few that are okay. But basically, you have to have a tight seal. If you're wearing a surgical mask, you can improve the seal by twisting the loop. And so instead of just doing the straight loop around your ears, you can twist it and it makes it tighter. And then you tuck the corner so the air doesn't come around the sides. But air has to go somewhere. And so it is going to tend to go up over your face. And if you watch that Washington Post video I told you about, it's very interesting to see how the air gets deflected. But I think even if you don't wear the mask, ideally, it still helps. It really dampens that direct flow of airborne particles straight out that's going to the person you're directing at. And I think it makes a tremendous difference, even if we all wear masks suboptimally. It's better than not wearing them at all.
Thank you very much for that. Another set of questions has to do with, we all want to be treated in a very good way and get it at stage 1, just like Giuliani and Trump did. So what are our chances? Yeah, why not? But so what are our chances, one, to be detected soon enough? So we're asymptomatic. So how do we know? Those guys were getting COVID tests every day just to keep track of them. But I don't get that. And that number 2, if you're you're diagnosed, can you get that cocktail that they get? If we went to Harborview, could we get that cocktail that those guys got?
So these Regeneron antibodies are not widely available, and I don't think the Lilly monoclonal antibodies are either. So you would have to be pretty well connected to get some of these things. But frankly, we don't even know for sure that they work or not. They're being used in this really sort of crazy way without a lot of data behind them. They probably are effective early on because they can neutralize the virus. But how much did they have to do with either Rudy Giuliani or President Trump, getting better? I really have no idea. Most of the time, we don't care if people are asymptomatic or mildly symptomatic and have COVID, except for spreading the virus. There's no treatment for this kind of early mild disease. The key is knowing whether you're on the trajectory to getting worse. So the knowledge is that from the onset of symptoms to the time where you start getting worse is usually about a week. And so when you first become symptomatic, if you have a sore throat and you have a little shortness of breath or a cough and you get diagnosed with COVID, then you look when your first symptom was, and that is time 0. And so then you go out from that, and that's the viral phase, and you're going to clear that because everybody clears their virus eventually. But what you want to watch out for is, are you going into that pulmonary phase? And that is going to primarily be shortness of breath. But one of the dangers is that we found that some people have what has been colloquially called happy hypoxemia, where they can become progressively desaturating the amount of oxygen in their blood, and they're not that symptomatic. And the physiology of that is complicated. I'm not going to go into it. But what it means is that it's actually useful to monitor your oxygenation. And so what a lot of primary care doctors are doing is they're telling their patients when they get mild COVID, if they're at home, they should get a little bit of a finger oximeter. I ordered one and got it from Amazon. It was, $25 or something. It's battery operated, and you put it on your finger and it tells you your SaO2, is 95% and you're happy. And so you can monitor yourself or your loved one by checking periodically. And if their oxygen drops down, below 93 or something like that, then you have to let your doctor know, because that could be a sign that you're moving to more serious illness, and you'll want to get some more blood tests and maybe even be admitted to the hospital. So I think in the outpatient setting, what we want to do is watch people, because most of them are going to get better. Most people with mild to moderate COVID do very, very well. Most of them don't need hospitalization at any point, and the ones who get hospitalized almost never die. So we just want to watch to find the occasional one who seems to be getting worse, and that might be the person you bring in the hospital and you try to give remdesivir or antibodies or whatever kind of therapy to clear the virus. So that's how I would deal with that, even with my own family.
Yeah. So I hear you for the measuring the oxygen on the finger, and you can get that for $20. I think that's a good idea. And then you've got the thermometers, and you can do that.
And there are blood tests that your doctor can get, that things like D-dimer. A hemogram is actually very helpful because you can see the white count, the lymphocytes go down, the neutrophils go up, the platelet count changes. There are these so-called biomarkers that people can get. C-reactive protein is a very cheap test. That tends to go up if you're starting to get inflammation. So they can get a few of these tests and they can see if you're in the group to watch or if you're in the group that looks like you're doing fine. That can be.
But if you don't have any symptoms, here's what I'm afraid of. I don't have any symptoms, and then I go to stage 2 or 3. I'm almost asymptomatic, still got the virus, but I didn't know it. So I didn't go into my doctor.
The vast majority of asymptomatic people do great. So you really don't have to worry until you start to develop symptoms. Okay. A lot of asymptomatic people don't even ever develop any symptoms. So I don't think you have to panic about that you could have silent COVID and suddenly the first symptom is going to be that you drop dead. That's not very likely.
So I was worried. Another person asked this one. How can we, is there anything that you know about, it's not really your area, but to get the vaccines to the poorer countries and the richer countries? A lot of the richer countries have bought up a lot of the vaccines. Is there any plan to get it to the poorer countries?
There's been a lot of discussion about this, and there are a lot of vaccines in development. And actually, I think the AstraZeneca vaccine is the most of the current front runners, is most likely to help a lot of these countries because it can tolerate room temperature. The Pfizer vaccine is very finicky in terms of its stability at higher temperatures, and you need -80s. The Moderna vaccine, I think, can tolerate -20, but still you have to have a cold chain. Mm-hmm. And so what we really need are these vaccines that are hardy enough to be sent to these resource poor areas. And I think that's something that a lot of people are thinking about.
Two things about this. One, I'm going to talk about homeless people. And it seemed like there were a lot of people infected, but they didn't get sick, so they had that 87% non-asymptomatic. They had the most asymptomatic, I think, positive but asymptomatic. And another thing is, why do you think that old people get it so severely? What is it about old people that makes them so susceptible?
So we actually don't have a very good idea, except that older people not infrequently will have dysregulated inflammatory responses to triggers which are handled by younger people. And it might be the aging of the immune system. So if you have a deficient initial type 1 interferon response, then the virus can stimulate this unbalanced inflammatory response. And it may be that's what's happening in some older people. Now, what's going on with the older people who aren't getting sick at all? We don't know. One of the interesting observations is that there are these coronaviruses that cause the common cold that circulate around. And a lot of people have cellular immune responses to those that have some cross-reactivity. It's still an area of active investigation to see if these cellular immune responses to colds that we might have had last year or the year before might actually be affording some protection against severe COVID. I think it's a theory right now, but it's probably as good as any in terms of trying to figure out why not everybody has the same degree of illness when they get sick.
Another question people had was, so you're an old person, so you might have this deficient immunology, like, because everybody has it a little bit. But if you're healthy, by and large healthy, your normal weight and you don't have any diabetes or any of the other things that you said, are those old people, even just by them being old, no other factors, just age, are they more susceptible?
So a lot of the susceptibility is comorbidities, and that you're more likely to accumulate medical problems as you get older. But that's not the whole story. So frailty is part of it too, that some people have looked and some people are old and robust and climbing Mount Rainier, and other people are falling all the time and they're really frail and they can't keep a lot of meat on them. And I think frailty is also a risk factor in and of itself. But beyond that, I think it's turning out that age is still a risk, even when you factor all the comorbidities out. It's not completely that, but it's partly that.
You didn't say about the homeless, the homeless.
Yeah, we've been definitely seeing a lot of homeless with COVID, usually mild COVID and sometimes asymptomatic, but it spreads very rapidly in that group of people, and they're not really able to practice distancing and to use the kinds of measures that that we try to use to protect ourselves. And so socially, one has to take a very aggressive approach to screening and identifying COVID in places where a lot of people who are living homeless are staying, and to quarantine them and to keep the infection from spreading to others in that population, because it is quite a vulnerable population in that regard.
Thank you for that. Two questions about comparing this corona virus to flu virus. One of them is that flu viruses mutate so quickly, so we have to have the thing every year. That's number one question. And number two question is that the rate of death is like 10 times more with corona than with flu. And that sometimes is not appreciated by people, like the rate of death.
Mm-hmm.
So, but address those two questions.
Yeah, so first of all, the flu virus, RNA viruses, most RNA viruses don't have what's called proofreading, a molecular mechanism to make sure they don't make replication mistakes. So when they make more copies of themselves, they make lots of mistakes and they generate lots of mutations. And this is incredibly common with flu. And so this is why every year we have to have a panel get together and look at the flu season and try to guess what the next flu season is going to look like and pick the most likely targets. And this is a nightmare with flu vaccines. Coronaviruses actually have a proofreading function. They have a protein that improves the fidelity of their RNA polymerase. And so they don't mutate at nearly the same rate. They mutate, and we've developed some lineages through the COVID pandemic that can be associated with certain areas, and some of them actually may have some impact on how severe the disease is. And our first wave of disease was pretty mild compared to New York City, for example. And I've been wondering whether that might have had something to do with the particular strain of virus that we had. But this is quite controversial as to whether these viral variants are different in virulence. Right now, it's not a settled issue, and whether they're different in transmissibility. But coronavirus does not mutate at nearly the same rate, but we may still have to get vaccinated every year because the immunity to coronavirus is not very long-lived. It can persist for months, but right now we don't know whether or not it's going to persist into the next season. Hopefully, with enough people having at least some immunity, there'll be a reduction in the threat, and we can, if we have to get revaccinated, it won't be so frequently as flu, but it won't be for the same reason if it turns out.
Do you think that the immunity from the natural disease is better or worse than the immunity from the vaccine?
In theory, I think the immunity of the vaccine could be better.
Oh.
The natural immunity, some people don't even seroconvert. They don't develop an antibody response, and they were PCR positive, and we know that they had the disease. And some people who seroconvert, they initially have a big response, but then they have this low level, what's called a memory B cell response. So they can make more antibody the next time they see the virus, but their antibody levels are pretty low. a significant percentage of healthcare workers who got exposed, who seroconverted, will not have a durable response if you look, 3 months later, they've become seronegative. It's about 25% of them. So the antibody responses are kind of middling to a normal mild infection. And I think the vaccine can give you a more whopping dose of protein and give you a more robust antibody response in theory. So I don't see any reason why the vaccine couldn't um, um, exceed the immunity that you would get from natural infection. The complexity of the immune response is different, because with natural infection, you have the whole virus and you're going to have cellular responses and different antigens and so on. It's hard to know exactly how that's going to play out.
That was a question, because
Yeah.
you might not be measuring the total of the body's response or the
Now we're all focusing on spike protein, but it may turn out that these cellular responses to other proteins may be important too.
Right. Okay, good. And then somebody asked about animal studies. You mentioned guinea pigs, but was that right?
It was hamsters.
Hamsters, I get those mixed up.
Yeah, and ferrets have been looked at. And non-human primates. I showed also a macaque monkey model.
Yeah. Do you think those are useful studies? And are there any studies that you think should be done with animals that haven't been done?
I think animals have turned out to be extremely useful for this. I think that we've learned a lot about the pathogenesis of it, but the disease in animals is always different, from the disease in humans. The severity of the disease that they get, you can only learn so much, and so everybody wants to know, is this going to translate? And so it's nice to show that macaque monkeys can be vaccinated and that they get milder illness. That was really reassuring, but it wasn't enough to give anybody the vaccine. We had to actually do a clinical trial. So I think there's some things, there's no substitute for doing human studies, but we've certainly learned a lot from the animal models.
Good. This is a real practical question coming up for the holidays. So this one was saying, okay, people say they're going to distance themselves and wear masks, but how about 10 people getting together and they're not in your bubble? They're relatives that are coming from across the country. How safe is that? 10 people.
I really don't recommend it. I think it's like Mike Osterholm, who is a really well-known epidemiologist who's on President-elect Biden's COVID team. He said it's like saying, well, you shouldn't drive while you're drunk, but if you are going to drive while you're drunk, here's how I would do it. We really shouldn't do this. We should not get together with people outside our bubble. We're in the middle of a surge, and we need to protect each other as well as ourselves. Get through this, get vaccinated, and have many more Christmases to come. So I think this is one that, unfortunately, I would recommend that we sacrifice. Mm-hmm. I'm going to be doing what you're going to be doing. I'm going to be sitting on a stupid Zoom session with my kids, opening up presents.
With a good drink, too. Anyway, but this one's about the supply of the vaccines. How many will Pfizer really be able to do, Pfizer or the Moderna or the only ones available? And then when would regular people be able to get them, do you think?
I think the scenarios I've seen, and I don't hold me to this because I'm just talking off the top of my head, but there's this initial wave of a couple million doses, and then there are these phases that are going to come in over the next 5 or 6 months, where the hope is that everybody who's willing to get vaccinated can get vaccinated, by the summer. And so I think unless there's really an unforeseen problem with production, there are also other vaccines that are close, that are going to be, ending their clinical trials in the early part of the next year, that are potentially going to be getting EUAs and being authorized to be distributed. So I think the more vaccines, the better. The more we're likely to cover every situation and cover the world. And we really need to cover the world. We can't just be protecting our country, because as long as there's COVID running around uncontrolled in the world somewhere, it's a threat to everyone. So interestingly, I thought this was going to be a terrible problem for Africa, but Africa has done really well. And
I wondered whether they had coronavirus exposure for a related one in the past, you know,
Yeah,
so
there's lots of theories about it. One of the biggest things is they have a lot of young people.
yeah.
And so the demographics have been really different. Also, the humidity and the temperature and these weather factors may have played in. And a lot of the African countries have been really aggressive at trying to use these social measures of distancing and masking and so on. But for whatever combination of reasons, they've done remarkably well. But still, they're going to need vaccine too.
I can see this is a personal question from somebody, but they are there, you've addressed this pretty much, but I think they want another more clear answer about data about the survival rate of the over 80s who have comorbidities. Do you want to say anything more about that? Like the rate was very high for comorbidities and above 80.
Yes, when you get into advanced age and you have a lot of comorbidities added, you start getting into fatality rates of 16-20%. But there are still people who do well. There was a woman who was so old that she had the 1918 flu and survived that as a child, and then she survived this. So she was over 100 years old. So there's no age at which you would say this is hopeless just because of age alone. There are people who have done extremely well with this virus, and for certainly all of you, I would hope for the best. But if you look at it as a population, it is a risk.
I think that's about all the questions, but I'm going to say to my co-hosts that did anybody see anything that I missed? Did any of you see anything, or did we get them all? It was wonderful. Thank you very, very much. And wouldn't it be great if Kitsap County now had the lowest rate of infection just because of Dr. Fang? I think let's give him a clap and yay for him.
Well, it's such a pleasure for me to meet with you all. I wish it could be in person, maybe some other time, but wonderful to see you, Jill. And
Okay.
Thanks so much for the invitation.
Well, thank you very, very much.
Take care of all of you and best wishes for the holidays.
Oh, thank you so much.